All right, guys. First thing I would like to do is congratulate everybody. I checked the quizzes from last week. Everybody did very, very well. Good job. Remembered the path of blood through the heart. Really, really hard thing to learn. So give yourselves credit and a good pat on the back because that is a toughie. That is for sure a toughie. Moving into tonight, we have a lot of material to cover tonight. Hopefully you've taken a look through the PowerPoint slides and gotten a look at what we're covering. So today we're focused on blood vessels. So we're going to talk about different kinds of blood vessels, how those vessels are made up, what makes them different from each other, and what's going on at every level of the blood vessel. And then we're going to turn our attention to the lymphatic system. We'll talk a little bit about that this week. And then next class, we'll pick a little bit more, and we're really going to focus on the lymphatic system next time. Grace is logging in. One more thing, I do want to remind everybody that next week we do not have class. No class next week. We will resume the following week, which I believe is the 17th. And from there, we will pick up right where we left off. We will just continue as though we're still on week 5. We're just going to keep moving on. All right, so let's get to it. Starting with blood vessels, we very briefly touched on these last week. So the 3 major types of blood vessels, those are arteries, veins, capillaries. Arteries, veins, capillaries. Grace says she's having computer issues. Okay. So arteries carry blood away from the heart. By definition, they always carry blood away. So I like to just remember that's what the A stands for in artery. A for away. Veins, on the other hand, by definition, are always returning blood back to the heart. Always coming back in a vein, always leaving in an artery. Now, capillaries are where these 2 vessels kind of meet. The vessels get super duper small. And that is where the exchange of materials will take place between the blood and the body tissues. So first, we're going to pay attention to arteries. And arteries are comprised of multiple layers. So first we look at the names of the layers. This is always going to be one of my sticking points when it comes to anatomy, guys. Before we talk about concept or anything else, let's talk etymology. If we understand what the words mean and what they're trying to tell you, usually we can start to infer what the function is going to be. We can start to take really solid guesses about the structure just by understanding what the name is telling me. So the layers of an artery are called the tunica layers. Tunic, like a tunic that you wear, like a wrapping, because these are layers wrapped around a vessel. Yeah. So the tunicas, we get 3. The intima, the media, and the externa, also called the adventitia. So look at what those names are telling you. I have an interna one, like intimate, like it's internal. Maybe it's inside the vessel, yeah? The innermost layer. Tunica media, the one in the middle. And then on the outside, we have the tunica externa, the outside layer. So let's start with the innermost layer, the tunica interna, or the tunica intima. Welcome to anatomy. Everything has 5 names. We all just have to move on. Interna or intima, both of these are saying this is inside of me. This is an intimate layer because it's very close with the blood. This layer is made of simple squamous epithelium. Now we got to go way back to like AP1 when we talked about different types of tissue, right? Epithelial tissue as a category forms the skin of things. It's the layer of tissue that will always be laid down anywhere the body comes into contact with the outside. And now we have to be really sophisticated about what we mean by outside, right? Because when I close my mouth, which doesn't happen often, so enjoy it while it lasts, but the inside lining of my cheek, that red tissue in there, that's epithelial tissue. It's not skin, right? It's not proper skin like we're used to thinking of. But when I open my mouth, that layer of my body, the inside of my cheek, is exposed to the outside. Yeah. And if I take a bite of food and I chew it and I swallow it all the way down my esophagus and down into my stomach and the entire tube through the alimentary canal, the inner lining is lined with epithelial tissue. So by simple squamous epithelium, simple tells me it's a single layer, not multiple layers. Squamous means flat. So this is telling me a simple squamous epithelium is epithelial tissue formed in one single layer made of flat pancake-like cells. Okay. Remember with epithelial tissue, we also had stratified tissue, which was tissue made in layers. We also had columnar epithelial tissue, where these cells are shaped like columns. We're not looking at columns here. We're looking at flat pancakes. And so when we zoom into this picture, you see that inner layer, all those little dots, right? Those dots are the nuclei in those cells. You see they are flat cells arranged in one single flat layer. Simple squamous epithelium. The tunica media is the more interesting layer. This is where a lot of cool stuff is going on. This is where we have the smooth muscle embedded in the layer so that the vessel can dilate and constrict to alter where blood's going. We also have autonomic nerves, which plug into those muscles and tell them what to do, right? So when you get cold and you start to shiver, your body is rerouting blood to the core and away from the extremities. We do this by twiddling the diameter of blood vessels, which will effectively shunt blood one place and away from another place. So this is the layer responsible for vasoconstriction, and it's going to be thickest in the arteries, because that's where this happens. The third wall, we see the tunica externa, also known as the tunica adventitia. The adventitia just means extra, added on top. Comprised lots of connective tissue, so it's going to reach away from the vessel to connect to other structures to hold the vessel in place. You don't want blood vessels just slipping and sliding around inside of you. You kind of want those things locked down. So it anchors and stabilizes the blood vessel so that as the body moves around, blood vessels do not move. They move with the body, but they don't move relative to the body. This vessel, or this layer, sorry, will be thicker in the veins than in the arteries. So one more little layer that I want to add on top of this, just to give us a picture. When we look at the three layers that we're talking about today, think about the walls of your house, okay? The external layer anchors, stabilizes. That's like the brick of your house, right? The thick external wall. Next, if you tear open the wall and look inside, what do you see inside of your wall? Plumbing, wiring, right? Crap like that. That's the tunica media. That's where we see autonomic nerves sending signals, right? So all the guts, all the really weird stuff is kind of tucked inside the wall. Finally, we have the tunica interna. It's the layer you would see if you're standing inside of a room. So you think of the tunica interna as the paint or the wallpaper that's on the wall. It's the layer that is interfacing with whatever's in the room. In this case, blood. Blood is touching one side of the epithelial layer. So we've got our three major layers. of blood vessels. Next, we're going to look at the types of blood vessels. The largest of all of them are the elastic arteries. Now, one little point that I always like to make whenever the E word bears its ugly head, elastic does not mean stretchy. That's not what that means, okay? You guys all played with silly putty before? What happens when you stretch out silly putty and you let it go? It just drops, right? When you stretch silly putty and you let it go, it does not snatch back. You stretch it, you let it go, it drops. That is that is extensibility. You can stretch it. But now think of like a rubber band. When you stretch a rubber band and you let it go, it snaps back to its original shape. That is elasticity. That's what that means. The elastic arteries, yes, they stretch, but that's not what we're describing here. They don't stretch, they snap back after they've been stretched. That's what the word elastic is trying to tell you. This occurs in the largest arteries, specifically ones like the aorta and the pulmonary trunk. These guys measure up to 1 inch in diameter. You want a pretty realistic image of what that will look like? A quarter. They are as wide as a quarter. That is, guys, for humans, that's enormous. Like, you don't get blood vessels much bigger than that. If I could, I'll draw one more little parallel for you guys. When you think about a human heart and the human aorta, you think the heart is somewhere, they say it's the size of your fist. It's not the size of your fist. It's 2 fists together. That is about the size of your heart. It's a little bit bigger than you think. If you take 1 fist, that's not quite that big. It's bigger. 2 fists interlocked with each other, that's about the size of your heart. This is a pretty decent size. That aorta of yours is about 1 inch in diameter. It's about as big around as a quarter. Now, just for fun, let's think about a blue whale, right? Largest animal ever to exist on Earth. The heart of a blue whale is about the size of a Volkswagen Beetle. And its aorta is large enough that a scuba diver could swim through it. It's a little tight. But dude, you're talking about an aorta that's like this big around, like someone could swim through it. It's mind-blowingly huge. So in you know, when you compare the two, 1 inch big aorta is like no big deal. But for us, at our size of things, that's as big as it gets, dude. These are enormous blood vessels. High proportion of elastic fibers, which helps it bounce back. Elastic fibers expand and recoil with systole and diastole. So with every heartbeat, right, the pressure spikes and the pressure drops. And then the next heartbeat, it spikes and then it drops. These blood vessels, with every heartbeat, they will expand and then contract, and expand and then contract. That's why they have to be stretchy, and that's why they have to be elastic. They have to bounce back after being stretched. If they didn't, they would expand and just, and that would be really bad. Now, part of the purpose of these guys with the expansion and contraction, part of what they're trying to do is to smooth the flow of blood so it's not so jumpy as we move into the next level of our arteries, the muscular arteries. Now, these guys are about 0.2 inches. So suddenly we got a lot smaller. We got a lot smaller, like 1/5 of the size. The muscular arteries will lead to the extremities or the limbs. So these are the arteries that are supplying the arm and supplying the leg with their blood supply. They have a very thick tunica media, which is the muscular layer, because they have a lot of constriction to do in certain circumstances. We all live in Oregon, yeah? You ever been so cold outside your fingers turn blue? That's because that artery heading down to the arm constricted up nice and tight to restrict blood flow to the arm, because you lose a lot of heat that way. We're trying to conserve heat, so we clamp down the blood vessels that head out to the arms and out to the legs. We open up the blood vessels to the core. And so proportionately, less blood goes to the extremities, more blood into the core. Thereby, we preserve our core body temperature. maybe not hanging out outside in the cold. Another way you've seen this, anyone ever eaten a large meal and then you get cold after you eat? You get a little shivery after you eat? Some people are like, no, Jessica's like, yeah. Because when you put food in your belly, all the blood's got to go to the digestive tract now. And so we pull blood from the extremities into the core and we get a little shivery when that happens. So there we have the last bullet point. They alter blood flow to large regions like arms and legs, right? As we continue down our track, we reach the next stage, which are arterioles. Arterioles are little arteries. They are like 0.001 inches in diameter. They are super duper small. Mostly consisting of smooth muscle, they will determine which capillary beds will receive blood. So back of the hand or front of the hand. Where's the blood going in these capillaries? They will also provide resistance to the flow of blood that increases the blood pressure. We need this at this point because most of the pressure from the heart has dwindled away, right? We're now, by the time we get here, we're in the hand or in the foot. So there's not a lot of blood pressure left. All that pressure got used up getting the blood here. So we use these thick muscular walls to squeeze the blood and get a little more pressure before we move into the next step, capillaries. Capillaries are the site of nutrient and other material exchange. So we say blood carries oxygen to the body. This is where we actually do the offloading of the oxygen and the onloading of carbon dioxide. It happens in the capillaries. We have a simple squamous epithelial layer combined with a basement membrane. Just a wallpaper, guys. The basement membrane is a thin layer of tissue. There is no tunica media or tunica externica. We are talking microscopic level here. In fact, so microscopic that your red blood cells have to pass through capillaries in single file line. We can only let these through one cell at a time. Incidentally, red blood cells are the smallest cells that you have. They're tiny. So, of the cells that you have, red blood cells are the smallest, and capillaries are so small, red blood cells have to pass through single file. Blood flow is controlled by the arterioles. Remember, they change the pressure to make sure blood keeps flowing. There are also precapillary sphincters. A sphincter is a ring-shaped muscle. It will clamp down on a capillary to reduce blood flow, or it will relax to allow blood flow. And if I had to, just a nice clean place to stick those. So you see the main artery on the left, and then it branches to the right. Then you've got that black arrow pointing. It says, there's the arteriole. Then you get 4 branches. I would put those little sphincters in one of those 4 branches. And that way, if I clamp down on one, I reduce blood flow down there, but blood will still flow up here. Good stuff. And the next thing, notice that they're all intertwined. We only reduce the flow of blood. We do not stop the flow of blood. Good stuff. Yeah, good stuff. So how does the blood flow within the capillaries? That will be determined by a couple of different things. Number 1, local chemicals, as in chemicals in the tissue. Number 2, autonomic input. Some good examples of blood flow being determined by local chemicals. Example number 1, injury. When tissues are damaged, they release chemicals into the bloodstream to signal that they're damaged, and we need white blood cells over here, right? I need cops, guys, over here right now. We use the hormone hotline, releasing hormones into the bloodstream to summon white blood cells to the area. If tissue is damaged, we need to reroute blood supply. If there's damage, just like traffic, if there's an accident, you got to reroute traffic around the accident. So we shut down certain blood vessels in order to deal with the damage, and we reroute blood flow around the damage. That rerouting and the way it's done is through vasodilation and vasoconstriction. That's regulated through local chemicals. The second example was autonomic input. That is from the nervous system. Remember, autonomic means automatic. So if the body gets too cold or the body gets too hot, the brain will autonomically reroute blood flow to make sure that we're preserving core body temperature. So local chemicals or the brain is how blood flow gets determined. So capillaries, we have continuous capillaries. These are continuous epithelial linings. They have small gaps between the cells. These are called intercellular clefts. This is just where two of those pancake cells stick next to each other, but there's going to be a little gap. So sometimes stuff can slip through the gap in between two cells. And you see when you zoom in there, it's those little cracks that you're looking at. Something really small could squeeze in between one of those cracks and exit the vessel. Now, you ask me, what kinds of things are going to squeeze out of a blood vessel? Molecules that are small enough to pass through will pass through. So what kinds of things? We're usually talking about smaller nutrient substances like vitamins. We're usually talking about small chemicals like hormones, like small molecule chemicals like hormones. What we are not talking about are large molecules like proteins. Like big stuff is not gonna pass through those little cracks. Interesting point, capillaries in the brain do not have intercellular clefts. So you can't just slip out of the blood vessel into the brain. You remember the blood-brain barrier? That's what that is. You can't just slip out of the blood vessel and end up in the brain. No, my dear, no, that's not how this works. You get caught in the brain without proper identification, those white blood cells will kill you on sight, like dead, shot in the street. All right, next we have fenestrated capillaries. And again, guys, I'm your friendly neighborhood etymology freak. Knowing the words and what they mean tell you a little something about what's going on. So I'm going to take a little side journey here. There is a really fun word called defenestration. Anybody heard this word before? Defenestration. This word means to kill by throwing out of a window. So if I killed you by grabbing you and throwing you out of a window, you have been defenestrated.
I've only heard that word via Scrabble.
Excellent place to learn new words. Yes. So defenestration, when we talk about what is the fenestration, we're referring to a window. That's really the root of what we're looking at. I realize that this has been quite a bit of a detour, but when we talk about fenestrated capillaries, notice that root word. We're talking about something related to a window. Fenestrated capillaries have windows that will allow larger solutes and larger volumes of water to be exchanged. So if you have something really small, we can slip it through the crack, through the cleft. If you have something a little bit larger, you can toss it through the window in a fenestrated capillary. And these little windows, you'll see there, they are pores. They're like little pores, holes that you can throw something through. Very much like a window. These guys will be found in kidneys, endocrine glands, small intestine, where lots of stuff has to pass out of the bloodstream. Nutrients, endocrine glands, we're talking about hormones. Kidneys, we're talking about lots of hormones that the kidneys make, and the stuff that they filter out of blood. So we need to be able to get stuff in and out of those little blood vessels. Now, if you were to take a window and just blow a hole in the wall, right? Like you're tearing down a wall to make a great room. Well, now you need a sinusoid cavity. That ending, oid, anytime you see that ending, O-I-D, that is a Greek originated suffix. It means ish, of, or resembling, or kind of related to, but not quite exactly. So a sinusoid capillary is a capillary with sinuses, with holes, much larger holes than those pores we saw in the window. Sinusoids are found in liver, bone marrow, spleen, where we need very large materials to be able to pass through that barrier and get out of the bloodstream. These allow large substances, we're talking about plasma proteins, sometimes whole cells, to escape. But escape, it's supposed to be, they're supposed to escape. So liver, bone marrow, spleen, we're talking about large proteins that have been synthesized. We're talking about large enzymes that have been created in the liver. We're talking about large white blood cells that are formed in bone marrow that need to get in and out of the blood vessels now. Good stuff? Cool, cool, cool. Don't worry about being rude, guys. If you have a question, just shout it out. Just jump on in. Okay. So before we move into the next topic, good stuff so far, layers of blood vessels, types of blood vessels, and now we're getting into types of capillaries. We have fenestrated, we had sinusoid, and we had continuous. Okay. Next thing we're going to talk about, how do substances get out of the blood vessel? How do we transport something from inside the vessel to outside the vessel? Generally, we have three options. First is called diffusion. Diffusion, by far, is the more common one. It is more common because it does not take any energy, no ATP. It doesn't cost me anything to diffuse across a membrane. Diffusion is a natural property. It just happens. Nature does it. Forgive me, I talk a lot to a lot of different classes. Did I talk to you guys about diffusion? I used the example of a big pot of water and we put food coloring in it. Yeah, we talked about that. Cool. That's the story of diffusion, right? When I put a whole bunch of food coloring in a big thing of water and I just leave it alone for a while and you come back, it's not dark blue in the middle and clear along the outsides. It's light blue uniformly throughout. Diffusion. So diffusion will occur with lipid soluble substances. So things that can dissolve in fat. These will diffuse through the endothelial membrane. If the substance is water soluble, it will pass through the intercellular clefts. Large proteins, and most importantly, blood itself, do not pass through the cells. Large molecules and blood have to find some other way to get out. They can't diffuse, is what I'm saying. Another way that we can transport material is through the use of vesicles. Vesicles are an organelle. If you recall from when you talked about the cell, vesicles are like storage organelles. They're used to store large amounts of material. Large vacuoles in adipose cells store adipose tissue. So your fat cells have really large vacuoles or vesicles, sorry, that are filled with fat. You also have vesicles that will be filled with things like water, nutrients, things like that. But the trick here is understanding how we use these vesicles to transport material. And this one goes back to the example of looking at globs of oil that when you leave globs of oil alone after you poured oil into water, all the oil beads and you let it sit there and these beads start to slowly merge and then slowly merge into one big large disc of oil just sitting there on top of the water. With vesicles, you have a barrier with some substance that you're trying to get to the other side of the barrier. And the way we do this is by packaging it in a membrane. That's the membrane of the vesicle. And you know what? I want to do this in white, actually. So the wall of the vesicle is going to be made of the same material as the cell membrane for the most part. So just a little less sophisticated. So what happens, if you think about how those blobs of oil, as soon as those oil blobs touch, they just merge to form a single one. As this packaged material comes close to the membrane, once those two bits of membrane touch, they merge together. So what you're left with is something that will look like this. Once those two merge together, now it is one single membrane, which means that material that we were transporting is now able to go inside the cell. If you notice, so large lipid insoluble substances are carried across in vesicles. And if you notice way over here in the corner, that's what we're looking at, those little bubbles. There's material inside those bubbles. That material is being transported either into a cell or away from a cell. And to give you this same example in reverse, right? Let's say now I have a different substance that needs to exit the cell and it has to be packaged before we can do this. It needs to be packaged in a vesicle. So I would say then, here's the material that's got to get packaged out. It moves near a membrane, right? As it gets close to the membrane starts to bulge around it. So you end up with something that looks like that. And then there at the bottom, those little pieces will just pinch off. And just like those oil blobs, once they pinch off, you now have two separate deals. Once those pinch off, the little guy is contained in a vesicle. And now that vesicle can go on and, you know, live its best vesicle life. It'll usually get pumped into the bloodstream. And then from there, it'll be bounced around until it reaches its target organ, wherever it's aimed for. But in this way, it can get, the reason that we would package it instead of just shipping it out, what if it ends up in the wrong spot? Or what if some other cell could use that material? And so the other cell takes it. And now that material doesn't get to its destination. So we package them to ensure that they arrive at their destination so they don't get snatched up by some other organ along the way. Sometimes it's because the material is too toxic to just be released into the bloodstream. You've got to package it in something. The second way to get something out of a capillary is through filtration. Filtration will usually deal with fluids, but I think the easier way to think about filtration is usually like a strainer or like a colander. So if you've got a whole bunch of stuff mixed together, you stick it in a strainer, everything smaller than the hole will filter out. Everything larger than the hole stays in the strainer. When we're looking at filtration, we have to be paying attention to the pressure that's happening within the vessel. So if the pressure is greater, then your net filtration is being everything pushed out of the vessel. High pressure pushes things out. So on the arterial end, we usually have a really high pressure, which is forcing materials out of the blood vessel. That's generally going to be the nutrients and whatnot that we're trying to deliver to the tissues. Towards the middle, the net pressure is pretty much negative, so not a lot is happening. But then we reach the venous end of the capillary. Now the net pressure is negative, and that negative pressure starts pulling substances back into the vessel. We saw something like this when we talked about lymph. and how blood plasma leaks out of the vessel and becomes interstitial fluid, and then it's taken back in to the vessel. We call it lymph again, but some of that fluid doesn't get pulled in, it stays out. That is eventually going to be lymph. So high pressure going in, high pressure will push substances out of the vessel. Lower pressure will pull substances back into the vessel. And this is the process of filtration. So now the exchanges have all occurred. We've pushed out all our nutrients. We've pulled in all of our waste products. And now the blood is beginning its journey to go back to the heart. Capillaries will start to merge into larger vessels, which we call venules. Venules are just little tiny veins, just like the arterioles. So these are small veins. They receive blood from capillaries. Those will merge and merge into larger vessels, which we then call veins. Veins at any given time are holding well over half the blood in your body. It's more than half the blood in your body is on its way back to the heart. They have very thin walls, and the word on the slide is distensible, meaning they can bulge. You can bend them and move them around. Now they need to, because they're holding blood. If you especially think about artery or veins in your legs, think about some of that blood down in your foot. It's got to make its way against gravity all the way up your leg. That blood is not constantly flowing. It's going to flow and then stop. And as the blood stops, it starts to pool. And as it pools, that vein starts to swell with all that blood pooling in there. That's the distensible thing. They bulge out. You guys ever seen a varicose vein? One of those big bulgy blue squiggly ones, you like run your finger across it and it like flattens out and then pops back up. That vein is distended. It's bulged out. And I talked at length about this last week. I remember. Veins have one-way valves, which prevents the backflow of blood. And man, that is some brilliant design, guys. Genius design on those one-way valves. So the next thing we're going to take a look at is how blood returns to the heart. Venous return. Well, number one, we know we have valves that prevents blood from moving backwards. So valves keep the blood moving in one direction. The question here is, how do we keep blood moving at all? In veins, there is no more blood pressure. Blood got down to single file line, folks. As we recollect all that blood in the veins, there is no more blood pressure. There is no more heartbeat. There is no force helping to push the blood along the way, all the way up the leg, back to the heart. So how does blood get back to the heart then? Well, we have three options. Number one, the skeletal muscle pump. You guys have felt muscle at this point. We know when muscles contract, they get very firm, and when they relax, they get rather soft. So just normal movement. I mean, just sitting up or standing up, sitting down, walking around, breathing, just the normal stuff you do contracts muscles. And as certain muscles get firm and relaxed, it puts pressure on the blood vessels around those muscles, which squeezes the vessel. Think about squeezing toothpaste. When you squeeze the vessel, you get a little squirt. And when you let it go, everything stops. So as you move around, you're assisting little by little, just little squirt after little squirt of pushing the blood incrementally along its way back to the heart. Skeletal muscles. Option number two, the respiratory pump. Every second of every day, as you breathe in and you breathe out, the expansion and contraction of the chest and the abdomen change the pressure on the blood vessels. So we will increase blood flow that way. So skeletal muscle contraction, normal breathing. The third way that we can encourage blood flow is through manual movement. That is massage. How do you get blood up the leg? You put your hands on the leg and you push the blood back up the leg. Swedish massage style. So there's a cross comparison of arteries and veins. Rather than spending time on this one, I'm actually going to pop us over back to this old guy. I really skipped over the layers last week because I really just wanted to harp and gush on about those one-way valves in the veins. But now we're actually going to take a closer look at these arteries. So you see the outer layer, but as we cut inside, we see, holy cow, how many layers? That's a lot of layers. This may even be an easier way to look at it like this. So you can really start to see how these layers move through the inside. The easiest layer to spot is going to be the tunica media, the middle layer. It's nice and thick right there. On the outside, you have the tunica externa. That's the one that's kind of a brownish color now, all along the outside. Then we have the external elastic membrane. That's the elastic part. That's what lets it snap back after being stretched. Then we have the muscular layer. Then we have another elastic layer, double elastic layers. The very, very thin basement membrane. This is a very thin sheet of tissue. And then we have finally the endothelium. That is your endothelial layer. This is made of simple squamous epithelial tissue. Notice all those little flat cells in there, all those purple dots, those are nuclei. And this is what the blood sees as it's passing through a blood vessel. That's the wallpaper that it has to look at. Super exciting. At least it's not floral print. So one more detail that I want us to understand when we're looking at this. That thick layer of smooth muscle can contract and narrow the blood vessel, making it much more narrow. This will increase the blood pressure. We can also relax the muscle, which will dilate the blood vessel. That will lower the blood pressure. How can I remember those two and keep those straight? Have you ever used a garden hose? Ever? Yeah? When you turn on the hose and just hold it, the water just pours out. But if I put my thumb over the end and narrow the opening, now the water shoots out. You narrow the opening, you increase the pressure. We see how that works? Blood vessels work exactly the same. When you narrow the vessel, you increase the pressure. Whether that narrowing is through muscular action, like what we're talking about, or if it has been artificially narrowed. I'll talk about that right now. When you look at this blood vessel, there's one thing that I want you to pay attention to. The diameter of the blood vessel. The inner diameter of the blood vessel has a name. It's called the lumen. The lumen. If a person is afflicted with a disease such as atherosclerosis, where fatty plaque deposits are being laid down inside the blood vessel, as those plaque deposits are put down, notice we decrease the lumen. Yeah? So why do people with atherosclerosis have high blood pressure? Because the atherosclerosis is narrowing the lumen. And this isn't a magic or an anatomy thing. This is a physics thing. When you decrease the opening, the pressure goes up. That's how it works. Good stuff. So, super important thing to understand. So, after the artery, and there's no hole on the inside, so just ignore how this works. There would normally be a little hole on the inside. Next, we make our way here. That really did not highlight well. It looks more brown than anything, but this is the arteriole. So we have an artery, and then we have an arteriole. The arteriole regulates the flow of blood into the capillaries. So then we get to the capillaries. This capillary bed is where the exchange actually happens. This is where oxygen and nutrients diffuse out, carbon dioxide and waste diffuses in. Blood turns from red to blue, even though it's never really blue, it's really always red. And now we are venous blood. We are deoxygenated, we are filled with waste. Nothing else for me to do but go back to the heart. So the capillaries merge and merge and merge into a slightly larger vessel called a venule. And then the venules will merge into the vein. Veins have a very, very thin muscular layer. They have not a lot of need to be really elastic and expand and contract and all that stuff like arteries do, because there's no blood pressure. Guys, this is a nice chill ride, okay? If leaving the heart is like some like crazy water slide, taking a vein is like floating down the lazy river. You just hop in a raft and drink your beer as you go. Veins are very chill, not a lot of pressure. There is no pump, right? Pumping the heart or the blood back up the leg. No. How do we get blood through the veins? Muscle contraction and breathing and gravity for the uppermost body. That's it. Ta-da. So we don't really need a super crazy thick muscular layer because we don't need it. And in anatomy, form always follows function. If you don't function to need it, you won't grow the form to do it.
I have a question.
Yeah.
How, I don't think you ever explained how the breathing does that. How does the breathing help with venal return?
Yeah. So as your lungs expand and contract with each breath, the volume and the placement of the organs in the chest cavity will change, right? As you breathe in, the lungs get bigger, and then you breathe out, the lungs get smaller. But not just that. Below the diaphragm, all your abdominal organs also, when you breathe in, they get pushed down. And then when you breathe out, they get raised, relaxed, back to their neutral position. So with every breath, all of your torso organs are subtly shifting position. They are all moving just a little bit. They are also replete with blood vessels. So as they move up and down, the moving of different organs against each other puts a little bit of pressure, which is a little bit of a squeeze. So you get a little bit more of a squirt through the vein. And you never stop breathing. So every breath, your blood gets a little squirt closer to the heart. Make sense? Yeah, good stuff. So normal muscle contraction, how do I get blood up the arm? I move the arm. I lift stuff, right? And you just move. And as those muscles contract, they push blood back on up the heart. Same thing with the legs. What's the best thing you can do to get blood up the leg and return venous blood to the heart? Walk. Put weight on your feet and walk. Yep, true story. Good question. So back to the vein, we have the thick tunica externa, right? A thick outer layer, and then an itty bitty thin little smear of smooth muscle. Just a little. if you put that much smear on a bagel, someone would throw it back in your face. Like, I need at least a 1/4 inch cream cheese on my bagel, please and thank you. We've got a very thin, is it even gonna highlight it for me? Probably not. We have a very thin sublayer. I'm trying to organize it here, guys. Here we go. Okay, tunica externa, then super thin tunica media, super thin muscle layer. Then we have the subendothelial layer, which just adheres it to the muscle. And lastly, we have the basement membrane. This is, again, going to be where your cells are. So there's, again, squamous epithelial cells, the wallpaper of the veins. Could be worse. And then another very tiny detail that you'll notice is that the walls of the vein themselves are studded with blood vessels and nerves. Nerves tell it when to constrict and stuff. But the blood vessels are for those cells. They do not get their blood supply from a vein. Vein is blue blood. They have to get arterial blood. So veins themselves still need their own blood supply. We do that by running arteries, little tiny arteries through the walls of the veins. When we say the system is interdependent, guys, it is really interdependent. You can't pull any one thing out of the body and study it by itself because they're all related to each other. Okay. Good stuff. Decent, at least. Yeah. Cool, cool. Let's take a quick break. Let's take a quick, like, 10-minute break. When we come back, we'll start learning some of the major arteries. Do not have a heart attack. I do not need you to memorize all of the arteries. There's like maybe 6 that you need to know. All the other ones, I really just want to take a tour and just learn where they live. 10 minutes on the clock, my friends. I will see you guys very soon.
I definitely, yeah, you should go to him.
Well, I probably won't be getting any ink done for a while, but
Well, I'm just saying.
once you graduate, I might.
All right, and we're back. Just like that. Okay, guys, so we said coming back from break, we were going to start to take a tour, some of the major blood vessels. What I want to kind of preface this by saying, number one, it is less important that we can name and locate every single artery and vein. That's not a massage therapist thing. Really, what we do need to focus on, though, is understanding where some of the major ones are and understanding how they're named. So if I were to throw a name at you, you could take a good guess as to where it is. That's usually good enough for us. So the first one, actually, I'm going to start out with some that you will absolutely need to know. We'll go ahead and do these first. We'll put a star on them, and then we'll circle back around. First thing, top of the list, number 1. There are 3 blood vessels that branch off of the aorta. You see them right there at the bottom. Those 3 are the brachiocephalic trunk, left common carotid artery, left subclavian artery. So right at the top of the aorta, starting on the, well, what you're looking at is the left side, but the client's right side. On the right side of the aorta is the brachiocephalic trunk. That trunk is going to then split into the right common carotid, which goes up the neck, and the right subclavian artery. It's called subclavian because the artery sits right behind the clavicle on both sides. On the client's left side, we then get the left branch of the common carotid artery and the left subclavian artery. So the brachiocephalic trunk, if you look at that name, what's it telling you? Brachy or brachio, what does that word refer to? Brachy or brachio, like brachii. Arm, specifically from the shoulder to the elbow, this part. The second word, cephal or cephalic, what does the word ceph or cephal refer to? Head. Head. Yes. A trunk just tells you it's usually one vessel that's about to split. We are getting to the point where we're about to split. So when we split, where are we going? We are going to the arm and the head. You see how we name that? Yeah. So brachiocephalic trunk, left common carotid, left subclavian. You will need to know the 3 vessels that branch off the aorta. It's just one of the ones, it's just one of those things. Now, next thing. If you look at this neck, you will notice there are 2 major blood vessels right up alongside the neck. That is the primary source for blood supply into the head, neck, face, and brain. Those are the carotid arteries, the right and left common carotid. This vessel, the carotid artery, that's the one you're feeling. When you put your fingers there and feel for a pulse, that's the carotid artery. You should be able to kind of like move your fingers around and really hone in. Find it just on the anterior border of the SCM muscle, inferior to the mandible, lateral to the voice box, right about there. You should feel a pulse. If you don't feel a pulse, sorry to break it to you, you're dead. That's the carotid artery. Now, if you were being bitten by a vampire, he is not biting all the way into the neck to hit the artery. That sucker is deep. What he is getting is the jugular vein, the vein returning all the blood down to the heart. Veins, you don't feel a pulse on veins. There's no pressure. Okay. Cool. So again, we're not focused on naming every single one of them. What I want you to focus on is how they're named. Notice right in the axillary region, we have the axillary artery. That's going to be your main artery heading down into the arms and hands. Looking into the head, two that I want to point out here, right on the side of the face, right in front of the ear, there's an artery running up on the outside. It's called the superficial temporal artery. Superficial because it's superficial. It's not inside the bone, it's outside the bone. Temporal tells me where it is. It's in the temporal region. Artery tells me what it is. It's an artery. The next one that I want to point out is the vertebral artery. If we have and I'm sorry to do this to you guys, but I'm going to whiplash you back to AP1 when we talked about bones and bony landmarks. Cervical vertebrae all have a transverse foramen. They all have a hole on the side. The hole is not empty. There's an artery, if you look closely, threaded through all of those holes, all the way up. The artery held by the vertebrae, vertebral artery. I do not think we need to know anything about blood circulation in a brain. We don't deal with brains in massage therapy. If you do, you're not doing massage therapy. Sorry.
Brain surgery, that's a completely different thing.
Yeah, no, I'm not saying one would never need to know this. I'm saying if you're doing brain surgery, you're not doing massage.
I feel like massaging the brain would be bad.
I actually had a brain aneurysm and had surgery on my brain. So it's kind of an interesting thing to look at, all my x-rays and everything.
I bet. When they did your brain surgery, did they have to keep you conscious for it?
No.
Okay. I know sometimes during brain surgery, they have to keep you aware to make sure that they're on the right spot. So they'll like run through flashcards or something like that with you to test which parts of the brain are active before they start cutting into it. But yeah, the brain itself doesn't register any sensation. So if you were to like massage someone's brain, they wouldn't feel it. Every time I say that, I need to back up. Okay, let me be clear. The brain proper itself does not feel sensation. It feels no pain or anything. However, the brain is contained by layers of connective tissue called meninges, right? Like meningitis. The meninges do experience sensation, yes, and so does the bone and the muscle and the scalp and all that other. So everything on top of the brain definitely feels sensation. The brain itself does not. So if you were to, you guys ever seen the movie Hannibal? About Hannibal Lecter? Do you remember that scene at the end at the dining room table? Oh, I don't want to spoil anything. Okay, it's like a 12-year-old movie, so I'm not really spoiling anything. But in the end of the movie, Hannibal Lecter is sitting next to this guy who he is clearly drugged and done a surgical thing where he removed the top of the skull. So the guy's brain is out, and it's Hannibal Lecter. You see where we're going with this. He's just cutting off pieces of this guy's brain, frying them up on a skillet, and then feeding them to the guy. And the interesting thing is, once you've numbed the skull and scalp, right, you make your incision, you remove everything, and now the brain is exposed. That's it. Once you're cutting into the brain doesn't feel it. You don't have to numb the brain.
Question then, like as far as headaches go and like feeling like your brain hurts, is that just nerves that, I mean, what if the actual brain doesn't feel pain?
Yeah. So the key there is the brain itself doesn't feel pain, but everything else does. So all headaches are, and you think about the kinds of headaches that people tend to have, right? The first is tension headaches caused by what? Muscle tension. So the muscles are pulling on the tissue and all the tissue of the head is responding to that pull. That's the pain. You could be talking about something like a migraine. This could be blood pressure, right? Like high blood pressure in the head. It gives you those throbbing headaches.
Right.
You could be dealing with something in the meninges. So some kind of inflammation of the meninges, like meningitis, will put as it swells, it puts pressure on the brain, but it also pushes out against the skull, and that hurts.
So like occipital neuralgia, that would be like a nerve, like an inflammation of the nerve.
Of the nerve, yeah, and nerves feel sensation. So
Right.
nerve inflammation, any kind of neuritis, yeah, that's going to light you up.
Sure.
So that's why I really have to be clear. When I say the brain, I mean only the brain, butt naked, by itself, like nothing else. Everything else will have sensation.
Right.
All the
Sometimes
factors.
it feels like my brain hurts.
After some of these anatomy classes, I felt like my brain hurt too. Yeah, but
The emotional damage.
well, I mean, if you wanted another piece of good news, your brain consumes a lot of energy, especially when you're learning material. Your brain is putting a lot of energy into retaining and filing away this information. So you ever sit in a really intense class and afterwards, like you're starving, studying burns calories, learning burns calories, a lot of calories, comparatively speaking. When I was in massage school and I would get through some of these anatomy lectures, I would be like, oh my God, I gotta go home and sleep. Like, I'm just so exhausted. You've burned a lot of energy learning and retaining information. At any given point, 25% of the calories that you eat in a day, easy, a quarter of all the calories you consume in a day, that's the brain. The rest of the calories go to the rest of the body. Another fun fact, of those calories, this isn't on a test, right? This is just me nerding out to you guys. But let's say there's all the calories I eat in a day. "25% of those calories go to the brain, 50% of those calories go to the skeletal muscles. The remaining 25% is for all of your other organs. Brains and muscles burn energy like nothing else. This is why you get super hungry after you've studied and stuff like that, because you've burned all those calories. That is why the best way to lose weight is exercise, because muscles consume more calories than anything else per capita in the body. So if you're going to burn fat, it's the muscles that are going to help you with that more than anything else. Anyway, back to it. Okay. So next blood vessel we're going to look at in depth is the aorta. We've already talked about the 3 blood vessels that branch off of the aorta, but the aorta itself is subdivided into a few sections. The first is, as soon as we enter the aorta, we have just exited the heart. I mean, we just passed through the valve. We are officially in aorta country. Boom, you're in the aortic arch. The little arch, as it sticks up from the heart, it curves posteriorly towards the spine and then drops down. That arch gives you 2 main portions. You have the ascending arch, where the blood is going uphill, and then the descending arch, when the blood is going downhill. This leads us to the descending aorta, the descending thoracic, and the descending abdominal. We draw a dotted line there, just depending on what chamber of the torso the aorta is in. So we have the descending thoracic aorta. It's descending because it's traveling downward, thoracic because of where it is. Once you cross through the diaphragm, we are now officially in the abdomen. We now change the name to the abdominal aorta. And this one, you can also feel the pulse. I don't know if you guys have done a lot of palpation classes yet or kinesiology, but when we're palpating for our client's psoas muscle, which is deep in the abdomen, you're looking for a muscle that's going to be found here, but super deep in there, like way down to the back wall of the abdomen. You're feeling for that muscle. And as you're deep in there and you're poking around, you're going to feel a pulse a very strong, unmistakable pulse. That's the pulse of the aorta. That sucker is that big around. It's huge. And the pulse is unmistakable. All the organs like vibrate with this consistent heartbeat coming from the aorta. All of the abdominal organs pull their blood supply from this aorta. If you look at the aorta way down at the bottom, the very bottommost part, you see how it splits in two, like an upside down Y? Those become the iliac arteries, and those cross over the hip. Those will become the femoral arteries, and each one carries blood into one of the two legs. So it really is just a tunnel that branches into two tunnels, and then those tunnels branch into two more tunnels, on and on and on, until you hit a capillary. Again, super cool diagram. No reason in the world for us to start naming arterial branches like this. This is not what massage therapists do. Looking at the lower leg, if you look, we'll start at the very top. You'll notice there's the iliac artery, what we mentioned a moment ago. So you've got the abdominal aorta. It branches into the iliac artery. That will then start splitting off into other arteries, the most important of which is the femoral artery, right there in the thigh. Now, the femoral artery is important for a couple of different reasons. Number one, it's the main source of blood to the leg, and therefore all the leg muscles. So, you know, a little important. But another reason why this guy is important is unusual for an artery. This guy passes very close to the surface of the body. Usually you find arteries deep, right? They'll be tucked along the bone, deep in the limb. Veins are superficial, close to the skin. So blood comes in deep, it diffuses out, and then along the outside is returned to the heart. The femoral artery, on the other hand, passes very close to the surface, right in the femoral triangle. And again, I don't know that you guys have talked about the femoral triangle before, but I will pull up a model just to show you generally where it sits. When we're doing massage on clients, there are a few areas of the body we have to be cautious of because of reasons like this. Blood supply, nerves, lymphatic vessels, all of these could pass very close to the surface. And we just want to be very cautious when we're massaging in these areas. We're not putting too much pressure on the area. So when I add in all the fun stuff and I zoom in, looking at the hip, I'm going to direct your eyeballs. 1, 2, 3. That little triangle formed by the inguinal ligament at the top, formed by the sartorius muscle on its lateral side, and the adductor longus muscle on its medial side. But all of these structures that are passing through that triangle are very close to the surface. So when you're pressing around in your client's hip, there's, I know my triangle isn't going to stay, but there we have the femoral artery. You will definitely feel a pulse in the hip if you're hitting the right spot. Right next to that, we have the femoral vein. So all the blood coming back up the leg. We also have right there in pink, the femoral nerve, innervating all the muscles on the front side of the thigh, all your quadricep muscles. And then the chains of little green blobs, those are lymphatic vessels. And the blobs are lymph nodes. So you have that cluster of inguinal lymph nodes. So this is why we are cautious in this area, is because the femoral artery is right there, right close to the surface. You can feel its pulse when you touch the hip, right about where your front pocket sits, right about there. Now, Remember what I said? You're in a tunnel and then the tunnel splits in two and then those tunnels split in two. So it's just more and more forks off the road. Femoral artery will eventually become the tibial artery when you get to the tibia. And that will then further divide into, you have the dorsalis pedis, the dorsal side of the foot, right? The top of the foot. And then you also have the lateral plantar artery, the artery on the plantar surface of the foot. Again, I don't need you to know all of it. I'm just, look at how they're named. You see the rhyme here? You guys see what we're doing? Yeah. So here's my point with this. If I throw something at you like fibular artery, where on earth do you think you're going to find the fibular artery? If you say anything other than the fibula, right? Okay, next, veins. You'll notice the naming scheme, very similar with veins. Occipital vein, right? Retromandibular vein. Retro means back or behind. So the retromandibular, behind the mandible, right there. We are looking at jugular vein. That's the jugular vein. That's the one that vampires are going after. Usually vampires are going after, if you look right there, the external jugular vein. That's why bite marks are always right there on the neck and not down here or way back there. They're aiming for the jugular. Although vampires will feed from almost any blood vessel, so femoral artery is also a favorite. I watch a lot of True Blood. Upper limb and thorax, brachiocephalic veins. We've seen that word before, brachiocephalic. So this is going to be veins coming from the head and arm that will then merge into a brachiocephalic trunk. Axillary vein, brachial vein, median cubital vein, cubital region, meaning the crook of the elbow. That medial cubital vein is usually the one they're aiming for when they give you an IV. Lower limb. So we've seen all the arteries bringing blood down to the legs. Now we look at the veins carrying blood up the legs. And what do we see? Oh, the same naming scheme as before. Yep. Tibial vein, femoral vein, iliac vein, and then finally the common iliac vein, where both of those rejoin. So here is, I'll take the bones away so we can see. So there's the basic system. In my app, that's just level 1. I can add more. You can see like whole hands and stuff, but it's not really important. What I want you guys to see there is the ascending aorta. And you can also see, I'm just going to remove this real quick. 1, 2, 3 vessels that branch off of the aorta. The aorta turns upwards. It aims posterior towards the spine, and then it turns down and runs behind the heart, posterior to the heart, anterior to the spine. There is your thoracic aorta. Now you'll notice where that pink highlight stops. That's about where the diaphragm sits. So we then pass through the diaphragm. Now we are in the abdominal aorta. Again, when you look at that, notice it's the same tube. We've just cabled off a section and we say, this is the thoracic section and this is the abdominal section. But the body does not give a shit what we call it, okay? We are the ones putting dotted lines and labels on things. The body just made a tube that branches out a million times. We went behind and gave all those branches a name so that we can talk about them. Common iliac artery, or you see, it's just the next section. And then we get the external iliac artery, and then the femoral artery. Same story with the vein. We get a femoral vein, we get an iliac vein, and then we are in the inferior vena cava. We have heard this one before. When we're in a vena cava, what's our next stop, guys?
The heart.
Be more specific.
Right
the-
atrium.
Right atrium of the heart. Very good. Very good. So once the blood gets up the leg, the next stop is to get through the hip. Once we're past the hip, it's smooth sailing from there. Now breathing will help squirt that blood inch by inch up the inferior vena cava. And as you can see right there, our very next stop, right atrium of the heart. Good stuff. Good stuff. Since I've got the fancy app up, there is the brachiocephalic trunk. And you can see it's going to branch into, there's the subclavian artery and the common carotid. So brachiocephalic trunk. We have the left common carotid and the left subclavian veins. All branch off of the aortic arch. Okay. So within the circulatory system, we have a kind of a subsystem because we have so much going on between the digestive tract and the liver. Remember that your liver is, it functions as a digestive organ. It's producing bile and other substances that aid in digestion, but it's also a filter of sorts. It's trying to detoxify the body. So if you eat something bad or eat something really nutritious, those materials either need to be, if it's really bad, it needs to be detoxified so your body can process it. And if it's really beneficial, then it needs to be distributed throughout the rest of the body. So now we enter the hepatic portal system. Again, knowing our etymology really, really helps. The word hepatic, if you think the root HEPA, like a HEPA filter, HEPA means liver. So if you have inflammation of the liver, you may have hepatitis. If you have a liver problem, you may need to go see, oh shit. I wanted to say herpetology, but that's not right. That's snakes. Hepatology, hepatology. Ugh, let's screw it. This is what's screwing me up, guys. Herpetology is the study of snakes, and a herpetologist is one who studies snakes. What I'm trying to say is hepatology and hepatologist. Sorry, words are hard today. I think I'm hitting my word limit for the week. Okay, so the hepatic portal vein. That word hepatic tells you we're dealing with the liver. It could mean anything else. The portal vein carrying blood to the heart. So we are collecting blood from the capillaries in the digestive system. It's coming to the liver. Those vessels will go to capillary again, now with no oxygen. The liver processes the blood from those intestines before returning it to circulation. The hepatic artery will receive oxygenated blood. The hepatic vein will return all blood from the liver through the hepatic vein. It's pretty straightforward stuff. And it looks all fancy when it's on a slide. It's pretty straightforward stuff. So hepatic artery, hepatic vein. That's how blood gets to for the liver. That's how blood gets in and out. The hepatic portal vein is how the liver can bring in blood, clean it up, and then take that same fresh blood, put it back into the body. Looks like this. Notice the numbers, we start at the bottom. First things first, the small intestine is absorbing products of digestion, nutrients, fats, proteins, carbs, all the stuff that you're digesting. small intestine's absorbing it. Those nutrients travel through the hepatic portal vein to the liver. The liver tests the blood content, too acidic, too alkaline, too fatty. What's going on? Once the liver has done its job, that blood enters general circulation by way of the hepatic vein. It goes out of the liver through the hepatic vein. From there, it ends up in the inferior vena cava, so we know it's on its way back to the heart. From the heart, we know what happens there, right? Right atrium, valves, something about lungs, we're cool. This way, after we leave the heart, we will either travel via the aorta through the hepatic artery. So we're heading to the liver and we end up in the liver. Pretty straightforward. Or we're heading through the aorta to the intestinal arteries. We go to the intestines. The intestines absorb nutrient-rich blood. That blood goes to the liver. In the hepatic system. If we bypass the intestines and go to like a leg, we're not ending up in the liver. You're going to the leg. Good stuff. Good stuff, guys. Grace, are we cool or did you freeze? Oh, you were frozen. Yeah, you were frozen just like, and I was like, oh my God, did I lose you? Did I lose you? We're good. We're good. All right, guys. Next up, blood pressure. We've talked about this already. We talked about this last week. I don't know that I have all that much new information to share about blood pressure other than let's just be technical. We are talking about the pressure that's exerted on the inside wall, right? The pressure of the blood pushing out against its container. As blood is traveling through the system, as it's moving, that pressure should drop. Blood will naturally flow from areas of high pressure to low pressure. That's just like diffusion. We don't have to do anything to make that happen. That's just how nature works. It just happens. High pressure to low pressure. Arterial pressure will be the highest. And as you look back at our blood vessel diagram, you guys will see a clear like line regarding blood pressure. Arteries have the highest pressure, right? Remember, thick walls, heartbeat, blood pressure coming over there. Capillaries have less. Veins have even less. Veins have just a none pressure, like none pressure. None pressure. Again, we've talked last week about systolic pressure versus diastolic pressure, right? The pressure when the heart is contracted, when the pressure is the highest, and the pressure when the heart is relaxed, where it is at its lowest. Normal blood pressure is 120/80. Should be right about there. Factors that affect blood pressure. So what can change blood pressure? Cardiac output. How fast is the heart beating? Because when the heart beats faster, that increases the pressure, the more flow of blood. Peripheral resistance, pressure in major arteries during diastole. This would be like where the atherosclerosis comes in. When the lumen is narrowed, even when the heart is at rest and the pressure should be lower, because the lumen is narrow, that pressure is actually higher than it should be. That's high blood pressure, that baseline blood pressure. This is why when you're diagnosing high, not you, because we don't diagnose, but when high blood pressure is diagnosed, you're not looking at the top number, you're looking at the bottom number. The bottom number is what tells you if you have high blood pressure or not. Yeah, if that number, if that 80 is something like 110 or 120, congratulations, you have high blood pressure. Doesn't matter what the top number is. Last, blood volume. If you make more blood, that will increase your blood pressure. Also, losing a lot of blood will lower the blood pressure. We learned about that last week when we talked about hemorrhagic anemia. Probably not important, but one more little detail that I'd just like to talk about since I have you all here. When you look at this chart and it rates blood pressure from like normal to high, you see the elevated range and you're looking at that and you're thinking, well, what if my heart rate looks like that when I'm at rest? That's still high blood pressure. It may not be severe, but that's the problem with high blood pressure. It really is a silent killer. There are no signs, there are no symptoms. The only way to know is to strap that cuff on your arm and check your blood pressure. You won't know if you have high blood pressure until A, you get your blood pressure checked, or B, you have some other major problem because of the high blood pressure. And by the time you start showing symptoms of high blood pressure, it's already too late. It's already too late. You've already damaged blood vessel. It's done. That's pretty much done. The best way to prevent high blood pressure is maintaining your weight and engaging in physical activity. You've got to watch the diet, because when the blood gets too fatty, fat starts to accumulate on the inside of those arteries and it reduces the lumen and it increases blood pressure. So how do you keep fat out of your arteries? You keep the fat out of your blood. How do you keep it out of your blood? You keep it out of your mouth. That's what you got to do. The other thing that I would say is, muscular activity is a really good, remember we just saw muscles burn half the calories you eat. So if you're going to increase anything, it needs to be that, like muscular activity, to burn more of those calories. But then you might say, well, Dave, if I need to like burn all this energy and get my heart rate up exercising, why don't I just do a bunch of cocaine and sit on the couch? Because I'm an American. And I would say that it sounds like a winning cheat, but exercise doesn't just increase the heart rate. Exercise increases the presence of a lot of different chemicals. And many of what those chemicals are doing are regulating the flow of blood to different areas, right? Tweaking the diameter of blood vessels to make sure blood is distributed to skeletal muscles. Other things that you're doing are increasing levels of stress hormones to encourage the body to adapt to changes in the environment, things like that. There's a lot of other chain reactions going on when you're exercising. Other parts of the body are benefited. Muscles are benefited by contracting. Bones benefit by having muscles pull on them, right? When you pull on a bone, it raises up a little more bone tissue to give that attachment more ruggedness so that it's a more solid attachment. So when you work out, you're not just building muscle, you're building bones and building strong bones by putting stress on them. So why can't I just exercise doing a whole bunch of cocaine or stimulants and not moving my body, right? Why can't I just snort a bunch of lines and sit on the couch and still lose weight? Because that's only part of the picture here. That's why. Increasing the heart rate is only part of what's going on when you exercise. So when you exercise, yes, you're getting an elevated heart rate and you're getting all these other benefits as well. Instead, when you just sit on the couch and like do a whole bunch of coke, you're getting an elevated heart rate, but you're not benefiting the muscle. You're not getting the release of stress hormones. You're not benefiting your bone tissue. You're not getting all the other chemicals and endorphins that are released through exercise. Quite simply, it's not enough. It's not enough. You actually have to put in the work, unfortunately. There are no shortcuts. Sorry about your life. Don't do coke, kids. Okay, good stuff, guys. Questions so far? Cool. I feel like we just went through a bunch of really heavy stuff. let's take a quick break. I know it's not quite an hour yet, but I feel like we just need to kind of decompress a little bit before we jump into the next stuff. 10 minutes, sound good? Cool. I'll see you guys in 10 minutes. All right, we are back. Good break, guys. Okay, so we wrapped up talking about blood pressure. Yeah, systolic versus diastolic. Factors that affect blood pressure. Cool. Regulation. This is what we're going to talk about next. Regulating the cardiovascular system. Cardiovascular system can be regulated in a couple of different ways. The first is locally, auto regulation. It happens at the local level, happens by itself. What we're looking at here is, remember we talked about local chemicals affecting like injuries and stuff. That's where we're going. So vasodilation, them getting larger, occurs in response to chemicals that are generated by metabolic activity or injury. So we could be talking about exercise. We could be talking about a scraped knee. We could be talking about the redness that occurs when you're laying on a heating pad and that heat is pulling blood to an area. So when you get up, that spot that was on the heating pad is super red. Vasoconstriction occurs in arteries and arterioles after injury. Remember, if something is damaged, we got to cut off blood supply and reroute around the accident. Vasoconstriction occurs when blood vessel walls are stretched, which kind of makes sense. Why would I want to constrict something that's already constricted? We know that it's dilated because those walls are stretched. So now I can start contracting them. Angiogenesis is the formation of new blood vessels, particularly after damage. So after a whole chunk of your arm has been cut off and now that chunk is regrowing, angiogenesis is the budding of new blood vessels, because we got to build new ones, right? So the next area of regulation is neural, as in nerves or nerve tissue or the brain, the nervous system. So the heart is under both sympathetic and parasympathetic control. That's both autonomic nervous system. Remember Spider-Man and Peter Parker. Arterioles are under sympathetic control. So stress response, Spider-Man system. Most of them will constrict, skeletal ones will dilate. So think about this. Arterioles under sympathetic control, that's Spider-Man, that's fight or flight. What happens in fight or flight? Most of your blood vessels constrict. The skeletal ones dilate. We're trying to send blood out to the skeletal muscles and to the limbs, arms and legs. We have vasomotor centers in the brainstem that will respond to baroreceptors and chemoreceptors. Remember, blood pressure and blood chemistry, particularly things like pH of the blood. When the brainstem catches a whiff of blood that's too acidic, the nerve sends a signal to the lungs to breathe more and get more oxygen in the blood to reduce the acidity. So again, we kind of talked about this already, but nerve control, we have local control, and third, we have endocrine control, which is control through hormones. Adrenaline, angiotensin, aldosterone, ADH, which is antidiuretic hormone. These are all hormones that will in some way affect blood pressure. Adrenaline is a stress hormone. It's triggered when we move into fight or flight response. Angiotensin, aldosterone, these are, and ADH are all produced by the kidneys. You'll talk about those way more when you do endocrine system in AP3. Endocrine is so much fun. It's so much fun. No, I love the nervous system. It's fascinating. The endocrine system, it's not my favorite. So the basic thrust here, I've already kind of explained it. It's just a really funny slide of explaining what I've already said before. When vessels get larger, more blood goes to those areas. When another vessel gets smaller, less blood goes to that area. So by coordinating which vessels get larger and smaller, overall, we can shunt blood towards a certain area or away from a certain area, depending on what's going on, depending on if it's an injury or a heating pad on the skin, something like that. And this is just kind of explaining kind of what's going on again, probably not anything we really need to worry too much about. These slides are really up there for what we need to learn at massage therapy school. All right. So as things change, how does the cardiovascular system compensate for these changes? Well, one thing we have is gravity, right? We are constantly being pulled down by the force of gravity. So the cardiovascular system is going to have to figure out a way of overcoming the pressure of gravity. One of these is the baroreceptor reflex, which causes increased heart rate and vasoconstriction. Prolonged standing can cause fainting due to decreased venous return. We see this a lot, actually. You see it particularly in military guys where they're standing at attention for long periods of time. And what happens is as they're standing, they lock their knees, which you're not supposed to do. When you lock your knees, it puts pressure on the vein behind the knee, which pinches the vein, reducing blood flow back up. And remember, when you don't have a lot of blood, the blood pressure drops. Remember that little tidbit? So if the blood is not returning to the heart starts to sputter. By sputter, I think, I don't mean sputter in the traditional sense. I mean, like, think about drinking a cup through a straw and you're getting to the bottom. So you're getting to that last like part. If there's no blood coming up to the heart, then there's no blood in the heart. So the heart is beating, but there's no blood and therefore no blood pressure. And what do we call a sudden marked drop in blood pressure? Fainting. You faint. That is what that is. So prolonged standing, particularly with locked knees. We also have orthostatic hypertension. Orthostatic, what you're getting at is bones staying the same. So bones are in a position sitting and they're not really moving. And suddenly when I stand up, all of a sudden, my blood pressure drops. Hypotension. When you stand up real fast and the blood pressure drops, you get real lightheaded and a little dizzy. Anyone ever stood up too fast? You know what I'm talking about? You stand up too fast, you get a little dizzy, you may have to sit back down and just rebalance for a second. Let me try this again. That is orthostatic hypertension. And these are just ways that the body, things that the body has to learn to adjust to. Heart rate, twiddling the size of blood vessels. Your body is really adept at overcoming these things. But sometimes it takes a second. That's why sometimes you got to sit back down first and then you stand up. Take two. We'll use take two. Another way we can help our cardiovascular system compensate: exercise. Skeletal muscle blood flow increases when you exercise. Funny, when you use your muscles get more blood. Funny how I know, right? Like, what? You don't say, you don't say. So when you exercise, as we all know from playing in recess, you start exercising, your heart rate goes up. When your heart rate goes up, cardiac output increases, the amount of blood, like measured in gallons. How many gallons is your heart pumping every minute? That amount goes up when the heart rate goes up. Because there's more blood flowing, and you're moving your legs, now there's also more blood returning to the heart. So exercising your cardiovascular system will result in a larger heart, which is a good thing. You want your heart to be nice and strong. It also stimulates the production of more capillaries so that we can get more nutrients to the tissues and remove more waste because they're having to work harder. So they need more food and they make more poop. And you got to deal with both of those. So more capillaries is our solution to that. We also increase the number of mitochondria per muscle cell. So we already know muscle cells have like a ridiculous amount of mitochondria. When you really start exercising and getting into a regular exercise habit, your body is going to start producing even more mitochondria. And you might ask me how. I'll give you a really quick side note. Mitochondria reproduce independently. They reproduce all on their own. They have their own DNA. It is not the same as your DNA. So when stimulated, they can reproduce themselves. And we don't build That's another one. When you exercise and you get all shredded like Arnold, you didn't grow new muscle cells like from scratch. Your existing muscle cells got larger. That's usually what happens. So when we talk about building muscle, you are to some extent adding new cells, but when you see the increase in the size of the muscle, most of what you're seeing is not new cell, it's bigger old cell. And the last thing, exercise increases the formation of myofilaments. That's the actin and myosin. You get more actin and myosin filaments so that they can grab more and pull more and contract more strongly. That's how we increase the strength of our muscles over time. We lay down new actin and myosin. So another thing that we need to be concerned with is shock to the system. And I'm sure you guys have heard before, probably in Grey's Anatomy or on House or something, someone's going into shock. Circulatory shock, there's several different kinds. But shock is defined as any condition that prevents blood flow to tissues. That is a very big definition. That's a very broad term. Generally, we're looking, we have hypovolemic caused by bleeding, vomiting, diarrhea, burns, right? Why are you going into shock? Major, massive damage. Large-scale burns, large-scale injury, chronic vomiting, chronic diarrhea. I don't mean like, oops, I went once. I'm talking about like, you need an IV and fluid transfer. You have lost so much fluid through the diarrhea. Major, major stuff. You lose all that water, guys. Remember, blood is half plasma. Plasma's water. So without water, blood isn't blood. Blood is like goop, and blood can't be goop. It's got to be liquidy. It's got to be flowy, right? If blood starts getting too thick, it's not good. So you can't get too dehydrated. You could go into shock, vomiting, diarrhea. Massive bleeding. We already talked about that, right? Hemorrhagic anemia, where you just, where's all your blood? It's all on the floor. And then burns will do it too. Vasogenic is caused by anaphylaxis. So you're going into anaphylactic shock. This can also be caused by really severe sunburn, like sun poisoning. You ever gotten a sunburn so bad you threw up? Is it just me, the one from Florida? Oh yeah, Celeste is like, yep, been there. We see it all the time, especially, no offense, my Oregon friends, but especially from people up north that come to Florida and they're like, woo, I'm on the beach. What's sunscreen? The Florida sun is no joke, bro. It will take you by surprise. You don't realize how strong that sun is until you look down and you realize, oh my God, I am a lobster. I have seen sunburns that got up into the 2nd degree. I've seen sunburns where people are blistered all over their shoulders and back, big blisters all over their sun and back because they didn't think about it. And way up here in Oregon, we do not get anywhere near enough sunlight to really prepare your body. When you live down south in the sun, you're a little acclimated to it. But even us natives down south, we still get sunburned. You still got to put on sunscreen. True story.
I was in SoCal and I got stuck in an inner tube down a lazy river and the river was going too slow. Yeah, not great.
Nope.
Not great at all.
No, not if you had sunscreen, it would be fine.
Oh,
But
I had sunscreen. It was the dehydration that got me.
oh, that'll do it too.
Mhm.
Yeah, that'll do it too. And you get a lot of those at the beaches in Florida too. It's like, oh, they remembered sunscreen, but you've been drinking beer since 9 a.m. and now you're out in the sun all day. And by 4 o'clock, they are like literally in the hospital. Yeah. Yep. Seen it all. Seen it all. All right. So let's look at these words. Again, I always go back to etymology because if you understand what the word is telling you, you can guess the definition, and that carries you so much farther. Hypovolemic. Hypo means below or under. That root vol is volume. So what are we saying? Like, what's the problem? What's causing the shock? Low volume, low blood volume with bleeding, vomiting, diarrhea. Why do you have low blood volume? Well, either all your blood is on the floor because you're bleeding out, or you're dehydrated due to vomiting or diarrhea. So you have no more water to make blood plasma. And if your body is really dehydrated, your body will start pulling blood plasma as water. And that means blood gets too thick and it doesn't pass through blood vessels like it's supposed to, especially those capillaries. Vasogenic, think vaso like vessel. Vas, that word vas, V-A-S, means vessel. So anaphylaxis, you're talking about your breathing vessels, like the bronchioles. And then cardiogenic failure, the failure is generated by the heart, cardiogenic. Why is your heart in shock? Your heart failed. It stopped beating. That'll do it. Every time, it'll put you in shock. So cardiogenic shock is the inability of the heart to maintain cardiac output necessary to meet the body needs. So your body is saying, I need this much blood every minute. And your heart is like, best I can do is 350. And if your body cannot get enough blood, the body does not function. That's the story. So this extra strain on the heart, having to pump harder to meet that requirement from the body, causes decreased tissue perfusion, meaning your heart is pumping extra hard to get all that blood out. And because of that, the blood is rushing through the capillaries and it's not given enough time to fully offload its oxygen and take on the waste products. So the tissues aren't getting their needs met. It's like a kid at a job, dude, you're moving too fast and you're not doing a good job. When the heart is beating that quickly, the decreased tissue perfusion is at the capillary level. The exchange isn't happening like it's supposed to. So by the time the blood is returning to the heart, remember, because it's happening really quickly, it's not fully loaded with waste products and it's not fully unloaded with oxygen. So when we go to the lungs and we're back and we go on to the rest of the body, we're not starting with a fully empty truck. You get what I'm saying here? That's why the needs of the body aren't being met. Symptoms of this include things like tachycardia, it's an uneven heartbeat, anxiety, delirium, dusky skin color, decreased blood pressure. You'll usually notice on that they look real pale. They look real pale. Their skin gets cold and clammy. They may like break out in a cold sweat. They cannot answer really serious, detailed questions. They can't think that deeply. You got to ask them real surface level questions. What's your name? What day is it? Who's the president? What causes cardiogenic shock? And I love your thing, systolic dysfunction or diastolic dysfunction. Well, the heart messes up either beating or relaxing. I don't know what the heart does other than beat and relax. But your systolic and diastolic dysfunction, something goes wrong with the heartbeat, or something goes wrong with the in-between phase when the heart relaxes. Arrhythmias, again, the heart is not beating on a regular rhythm, or it could be a structural problem. Many people are born with structural defects to the heart. Maybe they were born with missing a chamber of the heart, or maybe a valve doesn't function properly, so it allows blood to slip backwards in the track. Some people are born with a hole in the septum, the intraventricular septum, which allows the red blood and the blue blood to mix, and red blood and blue blood should never, ever mix. I don't mean to be a blood racist, but red blood and blue blood has got to stay separate, guys. They're chemically different. They've got to stay separate. So if you have a hole in your septum and this blood is able to mix, then just like the problem we mentioned earlier, starting off with a truck that isn't fully empty, right? Arriving to unload and you don't have a full load, it's not going to work out right. So structural problems become aplenty. And what is this? I'm not even sure what this. Oh, shock. Looks like cool info on shock. We're going to move right along. All right, we have just a few more slides on this one, and then I have a whole other slideshow, which, what time is it? 7:15. We'll see. We'll see. Let me try and get through this. We'll see how we do. Okay. So I know we've covered a lot tonight. I know we've talked about a lot of different things. Hopefully, what we realize is once Dave explained all this to us, this slideshow made it look way more intimidating than it really was. That's what I'm hoping. Because guys, it's what, I don't even know what this is. Don't stress yourselves out about this kind of thing. Focus on definitions, focus on key terms, focus on the things that I focus on, right? Like when we went over and over, path of blood through the heart, naming the chambers, naming the valves, right? We're not spending that much time naming every blood vessel. If we were in medical school, we would, but we're not, so we don't. Okay, age-related changes to the cardiovascular system. What kind of changes does the system undergo just due to normal aging, normal wear and tear? So keep in mind the status of the heart. This is a muscle that is very put upon. This muscle starts contracting weeks into your life in utero and will last, well, as long as you do. That heartbeat never stops. So what happens to the heart as it ages? Think about any muscle in the body that contracts too much. It gets too tight. It gets hypertonic, right? You feel that it's like, ooh, that muscle feels like a steel cable in your shoulder. Well, after beating every second of every day for your entire life, decades and decades go by, and suddenly that heart starts to get a little more fibrous. It's not as efficient. It's not contracting like it's really supposed to. That fibrousness just resists, the heart starts to resist beating to a small degree. It makes it less efficient overall. Next, remember, you've got these valves opening and closing on schedule, regularly, all the time. Any engineer will tell you the easiest place for your invention to fail is at the places where there are moving parts. So valves will degenerate over time. That is what leads to certain kinds of heart conditions like heart murmurs and things like that, and you may have to have surgery for it. And nowadays, they can just replace the valve. They just go in your heart and just swap it out with a new one. And by new one, of course, I mean one from a pig, naturally. So also, the coronary arteries can clog. Remember, our metabolism slows down as we age. And if we're eating really unhealthy foods, then all of the cholesterol gets caked on the inside of the arteries. That applies equally to all arteries: aorta, descending aorta, femoral artery, coronary artery, all the arteries. The coronary artery is the main blood supply to the heart, guys. So if the heart can't get its blood supply needs met, then the heart doesn't do its job. And that's bad. So have you guys ever heard of a particular heart attack? It's called the Widowmaker. The Widowmaker? A widowmaker is an informal term for a heart attack that involves 100% blockage in the left anterior descending artery. This is one of the arteries that feeds the heart. Understand, it gets a name for being so common. We don't just pick a name for some rare event. That's not what I'm, nope. Here we go. Much better. So notice at the top left, you see that left coronary artery coming right out of the aorta. That is where the heart gets its blood. And it followed around, it branches off. You see the circumflex artery. It keeps going, left anterior descending artery. So just to put some context on that particular artery, look what chamber it is sitting on top of. The left ventricle, which is the ventricle. That's the chamber that is pumping blood out to the rest of the body. So we understand why that artery in particular, the left anterior descending artery, when that gets totally blocked, we see why it's called a widowmaker, yeah? Because it will kill you dead. You may survive the widowmaker if the emergency room can treat you quickly. It is a race against time to unblock that artery, which usually means they have to cut you open. They go in with this super tiny little tool that's got like a little grabber on it, and they slide it through the artery. They grab the clog and they slide it back out. Voila, artery is unclogged. They have to do that within 90 minutes of the heart attack. 90 minutes. Why is it called the widowmaker? Because if it's blocked, your heart can stop very fast. Yep. It falls under this category, the STEMI heart attacks, the deadliest type. It happens when a coronary artery is completely blocked. So, whoops, I forgot my place. There we go. So I hope we're starting to understand why, man, heart attacks ain't no joke, bro. Ain't no joke. So when the coronary arteries get clogged, that's usually the end of you. You've got to see a doctor. If you have a heart attack, guys, minutes. You got to get into minutes, 90 minutes tops. Otherwise, there's not much else the doctors can do. We got to go in and clear the blockage, or we have to reroute blood flow around the damaged area. That's called a bypass. You ever heard of like oh, he had to have bypass surgery. Yeah, it's clogged. So I got to reroute blood vessels around the clog. You ever heard someone have a triple bypass? 3 clogs. Usually right in the heart. Usually all right there together in the heart. Serious surgery. That is an open heart surgery. They cut the sternum, they crack open the ribs, they literally, your chest open, heart exposed, beating in the air, and they got to go in there and do their thing. I cannot handle the stress of it. I could not be a heart surgeon. I cannot deal with the stress. I love this job. I like this job. Okay, so those are the things that happen to the heart, right? The heart itself gets more fibrous, its valves degenerate because they're constantly moving parts, and the heart's arteries get clogged. Its coronary arteries get clogged, causing heart attacks. Vessels also, blood vessels will start to become less elastic, and they'll start to become hardened by the plaque, right? Laying down that cake of fatty cholesterol inside, it starts to harden. Now, when the nervous system tells it to kick in, it can't dilate, it can't contract, it's hardened, it's stuck that way. And remember, we dilate to decrease blood pressure. So if I need to dilate and I can't, the blood pressure increases. High blood pressure. Venous valves can fail. And when those valves fail, blood starts slipping back and it will respond to the pull of gravity. So when we say it slips back, usually what we mean is it slips downwards in response to gravity. And the capillary walls begin to thicken, which can reduce the flow of blood into the capillary beds. So thereby reducing the exchange of oxygen, nutrients, and waste product. For the blood, remember blood is made from raw stem cells, and stem cell production usually decreases with age. So your overall blood production starts to slow down. You're producing numerically fewer cells. There is also increased blood platelet activity. Old people, their blood tends to clot really easily. And this can lead to blood forming small clots. And so like, where is all your blood? Well, it's kind of clotted together. They also tend to have increased cholesterol. Again, reduced metabolism. They don't change their diet because I've been eating this way for 40 years, eating steak and eggs for breakfast. And okay, well, cool. You could get away with it when you were 30, but now that you're 80 and your metabolism is slowed down, you're eating way too much cholesterol and you don't feel it, but your arteries feel it. All of them. How do we prevent all this stuff? Well, I hate to sound like a broken record, guys, but exercise. It's such a simple answer. You'd think I'm making it up, but no, exercise, like moving, putting weight on your feet and moving them around. It's the best thing you can do. And even better than that is to do it right now. Don't wait until you're 50 or 60 or 70 or 85. Start right now. I'm not saying you got to go, win the Olympics. What I'm saying is go for a walk. 30 minutes a day. Best thing you can do to prevent the aging of your cardiovascular system. Now we know massage has a lot of effects on the cardiovascular system. Most of these effects we can trace back to the link between the parasympathetic system, the Peter Parker system, the calm everything down system. When that system gets stimulated, everything gets calmed down. So look at number 1, vasodilation. When you dilate a blood vessel, you are bringing blood to that area that just got dilated. Have you guys done a massage and worked on an area of someone? And after you work that area for a little while, you move on and that area is a little pink? Vasodilation. In this instance, we call it hyperemia, strictly speaking. But what you are seeing is vasodilation. Because you moved a part of the body, those blood vessels dilated and it pulled more blood to that area. That's why it looks red. We also aid in the removal of toxins, which is my most hated word in massage. I hate the word toxins. It is meaningless at this point. What we mean to say is by massage and loosening up the muscle, that muscle has been holding on to blood, dirty, old, blue blood. And because the muscle is so tight, that blood is trapped inside the muscle. It does not make its way back to the heart. It does not recirculate through the body. It does not pass go and collect $200. It stays there until it's released. Who releases it? We do, by manipulating the muscle, right? Petrissage and effleurage and digging in. We loosen up the muscle, which increases circulation. Remember, circulation is one way. If you increase one, you have increased the other. They go together. So if I loosen up the muscle and I increase the intake of blood, you have also increased the output of blood. So all that really old, really dark blue blood, now it's in general circulation. It's going to get filtered by the kidneys and sent to the heart, and it's on its way. We don't remove toxins. That really bothers me. Your kidneys and your liver do that perfectly all by themselves. All we are doing is aiding circulation. We are facilitating the organs doing the job that they will do on their own if we interfered or not. Good stuff. I get a lot of pressure on that one, guys, from my colleagues in the massage world. They love the word toxins. I hate it. I hate it. I want it to die. I hate the word toxins. Let's just be honest with each other. What are we talking about? Cell poop. Cells poop. They eat and they poop. And where does their poop go? Bloodstream. So if muscles are tight and it's blocking the flow of blood, that's where the toxins are. It's not so much that they're toxins, so much as it's waste product. It's like poop or urine. You got to remove them. After exercise, after we've exerted the muscles, massage is very useful for enhancing recovery after exercise, restoring blood flow, right? Increasing the intake of nutrients. Yes, increasing the output of waste products. We're not using the T word. Increased blood flow, particularly to the areas that we're focused on, increased levels of muscle enzymes, and decreased work of the heart because we're increasing circulation, right? And we're dilating blood vessels. So the heart rate gets to drop. Whew. Good stuff. All right. I realize we've covered a lot today. I realize that. I'm thinking, but let me do a quick looky-loo, okay? Everybody, hold your breath. I'm gonna flip through a PowerPoint really quickly. Do not stress. I'm in control here.
The one for next week only has 20 20 pages as well as this one.
The
The lymph.
slideshow for the lymph
Yeah,
next,
yeah.
is it this one?
Mhm.
It's
The
not
the
the
lymph
same,
one and then the immune one.
but the lymph one, I mean, is it this exact PowerPoint
I think so.
for next week? Okay, because if it is, I'm not doing lymph tonight. I'll call blood vessels and we'll call it done. Yeah, I'm not starting that. We have 30 minutes to go tonight. I am not starting this. Dude, we'll be here till 10. So let me go back to Moodle.
Yeah, it is that exact slide. It just took me a minute to pull it up.
Thank you for doing that for me. I really appreciate that. So this
I was
week,
like, we're doing 40 slides today just with blood vessels. How long are we gonna be here? So when I looked and I counted.
yeah, no, I'm glad you did.
Yeah.
So blood vessels was today. And especially if it's the exact same slides, dude, lymphatic and immune, we will do that next class. So blood vessels is good for us.
And you were saying we don't have class next week.
That
it's
was,
the week after.
yeah, that was the very next thing I was gonna bring up. When I look at my calendar, and also don't have a heart attack when you see my calendar. I know it's intimidating. The 10th is our next slated class. I am out of town. So we just don't have class next week. Just enjoy your night off. Anything like the quiz that will be due before next class, that due date is pushed to the following week, the 17th. Nope, there, AP2, the 17th. So the quiz that's due, that will get pushed back. We're essentially just hitting a pause button. We'll take a week off. And then the following week, when I'm back in town, the week of the 13th and 14th, that's when everything will be due. We'll go back to our lectures. We'll have a midterm coming up. In fact, our midterm is week 6, which is going to be the 24th. Cool. So no class next week. If you log into Zoom, you'll be here by yourself. However, one more thing that I would mention to you guys before we break for the night. You guys already arrange your lives to be here at 5 o'clock on Thursdays. If we have a built-in day off of class, I would highly recommend a group Zoom study chat. If you already booked to be somewhere, don't have to, not forcing you to, just saying, be a really beneficial thing to do, especially with all this blood vessel stuff we just covered. Right. Any questions about anything that we've gone over? Any questions? Not about the tunica intima or nothing? All right, guys. Well, I hope you enjoy the rest of your weekend. I'll miss you guys next week, but I'll see you the week after. Take it easy. I will see you guys next week.